in robotic-assisted surgery. Welcome, Ignacio.
Yeah, thanks, Kelly. All right, so I will be presenting this work on behalf of my colleagues, Gilles, Geoffroy, Canlorbe, Jérémie, Belgihti, Guillaume, Morel, and Marie-Aude, Vitrani. So before I start, I have to say that some of the videos and images you're going to see might be shocking. It's real surgery, so you might want to look away from time to time. All right, so this is what open surgery looks like. So you can see the surgeons have a full view of the operating site. They can feel full haptics with their fingertips. They have full control of the tools and the material, so that's great for surgeons. However, for patients, the large wound leads to longer recovery time, increased blood loss, and other types of complications. Now, minimal invasive surgery, in contrast, is where surgeons use tools through small holes to operate, which means that the tool motion is inverted at the distal end. They have to see through a 2D monitor, and they don't have the full haptics. So that's not so very good for surgeons, although for patients it's very good because the small holes means they have low risk of infection, less bleeding, etc. Now, these two types of surgery have been joined by a third, more recent one, that is robotic-assisted surgery. So here, we put the surgeon in a console and a robot holding tools, and these tools are controlled by the surgeon at a distance. So this is what the console looks like, and this is how the robot looks like. This type of surgery has benefits for surgeons. As you can see, he's sitting down, his arms are rested, he's comfortable, so there are some ergonomic benefits. And also the tools are very precise and they have a high dexterity. There's no tremor of the image. Tools follow a very precise path with no trembling, and the distal end can move with many degrees of freedom. This system, however, is quite expensive. It's about 2.5 million euros at acquisition time. It has 100,000 euros of maintenance, maintenance cost per year, and it adds 2,000 euros per surgery. And what are the benefits for the patient? So far, most of the work in the literature say that it is about the same as the classic minimal invasive surgery. So there's a huge overhead in cost, and there are benefits for the surgeon, but we're not sure if there are benefits for the patient. Let's take a closer look at these two types of surgery. So on the top, in classic laparoscopic surgery, you see how the surgeon is sitting next to the patient. Sorry, he's standing next to the patient. In contrast, in laparoscopic surgery with robots, he's in the corner, isolated. The tools are grabbed by the surgeon and the assistant in the classic laparoscopic surgery, and below by a robot, which is on top of the patient. The assistants are roughly in the same position. They're both close to the patient. And lastly, the image of the laparoscope is seen through a monitor in classic laparoscopic surgery on top, and on the bottom, it's seen through a console where the surgeon sits. So robotic-assisted surgery emerges to have the benefits for the surgeons and for the patients from both types of surgeries. However, there is one important aspect that is telemanipulation. So why are the systems telemanipulated? Why do we put the surgeon in a console that is far from the patient and his team? Well, in the 80s, when these systems start to emerge, there is a great interest by NASA to be able to operate in space, right? To have the surgeon on Earth, be able to operate at the International Space Station. So the telemanipulated aspect is there from the beginning. It's not a design requirement that emerges from a need, but it's really part of what the funding is trying to put forward. Same for the Army. The US Army is investing in teleoperated systems for surgery to be able to operate in critical contexts such as battlefield. Now, a research question is, what are the impacts of having a telemanipulated approach for robotic surgery? To answer this, we performed a field study where we recorded both types of surgery, laparoscopic in its classic and robotic version. We used a fisheye camera to capture the interaction in the room, so the outside. We captured the endoscopic video feed, and a GoPro that was mounted on the top of the head of someone close to the patient. In this case, it's an assistant. And we used these 3 video feeds to analyze surgery. So we collected about 8 classic surgery videos and 13 for robotic surgery, and we performed 12 interviews with surgeons and their teams. And then we performed thematic analysis as defined by Brown and Clark, with an inductive approach. And we have this data validated with surgeons. So we iterated 3 times, making diagrams, going from specific to more general, until we constructed 3 themes. These 3 themes, I will describe them one by one, starting with the first one, which we call the autonomous but withdrawn surgeon. So why is he autonomous? So this machine gives him a lot of control. He can control the 4 arms through the console, and this means that all the surgical gestures are performed by the surgeon. And as a result, there is an autonomy from the assistant. So all the surgeries are more equal or all more homogeneous across patients. However, there are some unintended effects, such as overloading the cognition of the surgeon and withdrawing the surgeon from the patient and the team. Let's look at 2 examples. Here I will show you how having to control all these tools at the same time means that it overloads the cognition of the surgeon and he ends up pushing the wrong pedal. As a reminder, this is what the console looks like. And here you see 2 pedals, one from the left tool, one from the right tool, and they're both controlled by the right foot. So here you see the surgeon doing surgery. And on the left, we see a feedback from the system saying he's pushing the left pedal, and we see a spark on the tool that is cutting the skin. And whoops, here he pushes the right pedal. So this is clearly a mistake because he's clearly operating with the left tool, and he quickly stops that motion and pushes the left pedal again. Now the surgery continues. And if you think that I might have made a mistake and mistagged this moment, here we see that there's clearly a mistake as he pushes the right pedal, but the tool is outside the field of view. So a surgeon would never push and activate a pedal that cuts when it's not seen, right? Then he corrects himself, he pushes the left pedal, he cuts, surgery continues. And again, he pushes the right pedal to activate the right tool by mistake, quickly stops, goes back to pushing the left pedal. Now, with confronted with this segment of video where he makes 3 times the same mistake, he says that in classic laparoscopic surgery, he can move the pedals as he wants, put them on the left foot, on the right foot, and here the system is really making him operate in a way that he's not used to, and he has to be aware of the movement of the joysticks, of the buttons of the joysticks, on the bottom of the console where he has the pedals, that it's only the right foot that controls the pedals, and this is just too much for keeping in mind at a given time. The second effect of being sitting at the console isolated is that it withdraws the surgeon from the surgery room. And we will see an example of low situational awareness. I want you to focus on the intern on the left. Oh, I forgot to plug the sound. So the intern is avoiding being hit first. And I want you to pay close attention to this robotic arm with this cable that is going to loop through this other arm. Right, so now the cable becomes detached. As you can see, it's looped. And being detached is not a problem. The problem is that now when the surgeon pushes one arm, it moves the other one as a consequence. And when confronted with this video, we're watching this over lunch just after the surgery, the surgeon said, see that? That is really dangerous. If I had moved the camera, it would have pulled and moved that arm, then the tool can hit anything inside. So luckily this surgery just finished after this moment, so nothing went wrong. And also the surgeon would have noticed this in the long run and had asked the assistant to kind of check the cables. Our second theme, we call it shifting the use of perceptual senses. And this refers to the fact that the console eliminates haptic sense for the surgeon. Now think about this, surgery without haptics. That's quite a change for a surgeon. And this has some effects. So they will compensate for the lack of haptics with visual feedback and with verbal feedback. Also, the fact that they cannot see their team will be compensated by verbal instructions to the team. Let's take a closer look at these examples. One effect of not having haptic feedback is that whatever is outside of the field of view, you cannot feel it, right? So if you pay attention to this tool on the right, it goes outside the field of view because the surgeon moves the camera. And now, when the surgeon goes back, boom, he's pulling on tissue. Now, clearly, he didn't intend to pull on this tissue, so he continues. But if this was classic laparoscopic surgery, he would have felt the force of the tissue, and he would have not pulled very strong to break it. He would have immediately looked with the endoscope and see what's caught up in his tool. When confronted with this, surgeon says, well, but I can touch with my eyes, except that what's not visible on the field, you cannot see, thus you cannot touch. Now let's look at an example of verbal instructions, and when these verbal instructions even fail. If you focus on the top video on the left, the surgeon is trying to activate the left tool. There's no spark, so it doesn't work, and he says, the tool doesn't work. He continues, and he says, can you plug the cable? If you take a closer look, the assistant didn't hear the instruction, is not paying attention, and it's just waiting. So nothing happens. Everyone's waiting for each other. A second surgeon says, yes, the monopolar scissors don't work anymore. Now she finally understood the instruction. I mean, there's a lot of noise in the room, right? You have to understand that she's looking at the screen, she's trying to understand what's happening. There are two surgeons operating, talking among them, so she doesn't know if the instruction is for her, for the other surgeon. And now the surgeon has decided to come to the surgical field to talk to the assistant. And he says, yes, the scissors, plug the scissors correctly. There. Look, the cable is unplugged. So this is a case when the surgeons do verbal instructions with the interns, and it gets to a point where it's not enough, so they have to leave the console, which is the place where they're concentrated doing surgery, to come back to the operating field and get something done. And a last example about how not having contact with the team, so visual contact with the team, has an effect. In this example, you will see how an intern takes a hit by the robotic arm. So the surgeon is operating, and he doesn't see the effects of his arm movements outside of the patient, right? I mean, his head is on the console with the stereoscopic vision. He's not looking at the patient or his team. And if you pay closer attention here, in the arm that is highlighted with the red thingy, bam, it hits the intern. So he doesn't know that the motion he's doing with the robotic arm will end up hitting the intern. So they had to stop surgery for some minutes to let the intern recover. Yeah, she was not happy. Third, we switch from the surgeon to the assistant. So this thing, we call it from surgeon assistant to robot assistant. And this is really about the interns that help the surgeon and how their role is changed radically. These assistants perform fewer surgical gestures and more robotic support. So instead of assisting the surgeon, now they are technical support for the robot. They have to unplug and plug cables. They have to make sure the tools are not tangled and cables are tangled, etc. I have a video here showing an accelerated footage of the surgery room. And on the left, you see how the assistants circulate around the robot and the patient, and they're not really interacting with the patient and barely interacting with the robot while the surgeon is in his corner operating. If we contrast this with laparoscopic surgery in its classic flavor, we see how they're together, operating, both at the same time, both using their hands. And this really breaks the teaching model from surgeon to intern, right? So fewer surgical gestures means, first, there are higher chances of distraction. One of our surgeons says, for an intervention of 5 hours, in the end, it's painful as you are focused and you hear 3 different conversations of the weekend, tomorrow's shift, the program of the hour next door. It's just unbearable. So everyone's talking about their weekend, and only the surgeon is concentrated doing surgery. Sometimes he has to stand up and say, shut up, everyone, let me concentrate. A second effect is that they learn less. They acquire less surgical experience, and this is because they're not performing surgery themselves, and the surgeons don't let them use the console, as this requires a lot of training, a lot of hours of simulator, and it's not taught in surgery school yet. One of our surgeons says the interns are not focused, they don't follow, communication is hard, so they don't learn anything. So these three themes, I'm not the first to observe these kind of things, right? The communication issues, the fact that the surgeon is isolated, all this stuff is here and there in the literature, but what we put the weight on is the telemanipulated approach. So the fact that the surgeon is away from his patient and team, and how this tool is supposed to be designed to help the surgeon, and in the end there are all these unintended consequences that hinder his work. So we wonder what's in between these two types of surgeries, and we propose to use the distance from the surgeon to the patient as a design dimension for this type of systems in the future. So if we put this design dimension as a continuum, on the left we have classic laparoscopic surgery, where the surgeon is actually touching the patient and next to his team. And on the far right, we have the surgeon being pulled away from the room, so being on another planet while he's operating, right? So really, really far away, remote telemanipulation. On the left, we have the current state today, the fact that it's remote but in the same room, so operating room telemanipulation. But we could also think of the future where the surgeon is brought close to his patient and team and operates these robotic arms with a smaller console that is sterile and that he can also let go and operate directly on the patient. This is sterile field telemanipulation. Or get rid of telemanipulation altogether, make smaller robots, get rid of the console, and have the robot and the surgeon co-manipulate the laparoscopic tools. So this would be co-manipulation. And now we think that HCI can play an important role on the future of the design of these tools, especially how to couple the high dexterity input and output without having to separate the robot that performs the action from the tools that sense the motion of the hands of the surgeon. So with that, I conclude my talk, and now it's time for discussion. Thank you.